So welcome everyone to today's panel on distributed ledger technology in the healthcare industry. My name is Christine Kim. I am a reporter for CoinDesk and will be your moderator for this afternoon's panel. We'll be talking about the current landscape of the US healthcare industry and in what areas distributed ledger technology, of which blockchain is a particular strain, is proving to have an impact. The speakers with me on stage will share their insights from the field about the lessons they've learned about the technology and its use case in the healthcare industry. I am joined by three expert speakers: lead enterprise architect at US healthcare provider Humana, Kyle Culver, along with CEO of blockchain-based identity Civic Technologies, Vinny Lingham. And finally, last but not least, I am joined by Corey Tadaro, the CTO of blockchain healthcare platform Hashed Health. So to begin, I'd like to acknowledge first that when we talk about healthcare and when we talk about distributed ledger technologies, we're talking about two very, very broad subject matters. So to put our conversation in focus, let's first talk about healthcare provider data on the blockchain. Kyle, how pertinent, plausible, and otherwise positive of a use case do you see leveraging blockchain technology for storing and sharing healthcare provider data?
Well, with the Synaptic Health Alliance, which Humana is a founding member of, we are exploring that use case, focused very specifically on the demographic data of the provider in that directory data. So meaning, if you go to your insurance company's website and you try to find a doctor, in your area, and you're looking for their phone number and their address, that maintaining the accuracy of that data. And so across the industry, there's a lot of duplication with that, as well as a quality issue, when we start to look at the audit results across that space. And so our group of 7 members have pulled together and said, hey, we think this is a great starting point for us to learn. Some of that comes from the fact that it's the shared issue, but then also it's public data. That we're spending a lot of time on. And so this really, I think, is interesting because it drives the conversation around what should be collaborative, right, and what should be utility versus what should be competitive. And do we really want to spend resources and time, right, competing over directory data, or is that more utility? And looking at that and saying, hey, if we learn how to work together on this, that should be a springboard for us to learn into other things.
And Vinny, coming from the background of building an identity platform, do you have anything to add about these use cases that Kyle had just mentioned about healthcare provider data on the blockchain?
Yeah, well, first of all, I just want to frame the conversation in the sense of, like, some of these use cases are obviously very relevant in the US, and when you get outside the US, it dramatically changes. I mean, if you look at the way healthcare is delivered in Africa and other parts of the world, it's very different, right? Having access to information and healthcare provider information is different. The compliance laws are different, et cetera. So when we look at our role in, call it healthcare DLT adoption, it's really about, we're a privacy company. We focus on creating the right environment to, as a user, store your personal information, your privacy, your identity credentials, and anything related to your healthcare conditions, et cetera. So we don't believe in storing data on the blockchain. We believe in storing data on your devices and giving authorization to people to access the data, whether it's through a zero-knowledge proof or sharing the actual underlying data in a way that is safe and secure and private. So I'll give you an example just to frame it. In Africa, there's a lot of healthcare that goes from the US to Africa for dread diseases, things like HIV, et cetera. But there's a lot of stigma attached to these diseases in those areas because you've got people living in rural villages, you have people living in small towns, and so if someone's infected by a disease, they don't want people to know about it. They actually don't seek healthcare. They don't want to go to the pharmacy. They don't want to, because word travels and they'll get ostracized to some extent. So we look at things like, can there be automated vending machines in those markets where you could actually privately go and get your machines, and there's no human in between that's looking at your data, that the machine knows that you've got a disease, you've got a prescription, you can get the drug issued. So I think the way we deliver these solutions using digital ledger technology differs from country to country. So I want to just preface what I say with, like, we have a more global view on how this is done.
No, that's a good point that when we talk about healthcare, there's also various different cultures and norms in different parts of the world when it comes to healthcare provision. But speaking to some of those real world applications, Corey, do you want to talk, as I understand, Hashed Health has worked on some very real blockchain applications in the US healthcare industry in particular. Can you tell us about some of those key takeaways and lessons that your team has learned from trying to implement the technology?
Great. Well, thank you so much for allowing me to be here and talk about our work. Kyle and Vinny, it's great to talk with colleagues again, peers. Hashed Health has been working on a number of projects. Primarily one is Professional Credential Exchange, which is actually a physician credentialing solution set to alleviate mostly hospitals and health systems as they go through the process of credentialing and privileging a physician, which has a direct impact on whether or not they can bill, which goes directly to the bottom line on the revenue cycle side. It's an administrative nightmare. Usually about 45 to 60 days to do it today with fax machines and paper still and armies of staff services people. And one of our project in that work, it's a partnership called Professional Credential Exchange. What I think is interesting is that it looks at the notion of intangible assets that all enterprises are sitting on mountains of, and they've never realized the value of, well, they realize the value of the data. They've invested a lot of FTEs, they invest a lot of infrastructure in generating that data and storing it, but there's no way to make it fundamentally liquid. And what PCX is really designed to do is to help those enterprises understand that there's not only value in what you did, which was produce and confirm a credential of a physician, and you do have to confirm it or verify it according to the regulations. That verification itself is now an asset, and that asset is valuable to other parties, your peers in your market, or your peers in a geographical region. And that's one powerful thread that we're looking at. The other bolus of work that we're doing is mostly on the transactional basis. And that is looking at contract structures in healthcare, which are really complex and multi-party and multi-step. And the amount of friction that's involved in that is tremendous. Average physician gets paid within 60 to 90 days, depending upon the payer. About 14% of 14 cents of that dollar that they get is spent on just hiring people to process that payment, just managing their claims. That's insanely high. It's 7x what it is in retail for revenue cycle and management of the payment there. But I think that dynamic itself points out one of the difficulties in healthcare as we think about DLT and blockchain, and that is in healthcare, maybe there are other industries, I know healthcare, it's the aligned incentives are they're hard to find sometimes. It's a very complex industry, and I liken it to 5 or 6 people with knives in a dark closet. They will stab each other. And when we talk about fixing inefficiency, we always have to think, well, somebody's making a pretty good day out of that inefficiency right there. And so when we think about making things more efficient, we have to understand the politics that are going on in healthcare between pharmaceutical manufacturer, between health plan, between provider organizations, hospitals, and the innumerable other players who sit between that triad there. And who are making things work today the way they like it to work today. And so change in and of itself is difficult in healthcare because of this kind of triangulation you have between these similar but very vested interests.
Right, and speaking to some of those more challenges in the US healthcare industry, that doesn't necessarily have to relate with implementation of technology, but more about the culture and the norms that have simply been established for many, many years. Kyle, do you want to speak more deeply, coming from a background of traditional, how healthcare providers normally act and view new technologies and how they adopt them? What role do you think that culture of healthcare providers interacting with all these other moving parts impact? Help advance or maybe hurt the use cases that Corey just talked about?
Sure, and so I think with that, the culture, that there's 2 different things to consider. There's one of adoption of new technology, And if anybody's been around their provider's office and seen the number of faxes that go through, I think we'll understand that there needs to be an incentive there. It's not that there's not a better technology, but we need to understand what the incentive is, make sure that that's aligned, so people kind of understand, hey, if I switch from this to something else, right, what the benefit is there. And then there's also the culture of collaboration. You know, going back to Corey's example of people in the dark closet with knives, like we have to understand the environment and then also kind of where those incentives are. And so I think that's been an exciting thing to see as part of Synaptic. And then also, you know, outside of Synaptic, and see other people kind of coming together and doing work together with their competitors and looking at what are these opportunities for collaboration, how does this work, how can we work together, and having those conversations around the opportunity space and what's a good learning point. You know, I think starting with some of these more aggressive, you know, things that are farther down the road are tougher conversations, and so to see people pull back and say, hey, let's start with, you know, like public data, or let's start with credentialing, or let's, you know, and then also, you know, when we look at identity, right, identity and consent, everybody's saying, hey, there's a cost to this, right, there's an issue, there's friction in the system because of this, and so how can we collaborate and figure that out, because it's something that we're all currently dealing with.
And Vidi, to what Kyle just said, what do you think are some of the ways that we can incentivize blockchain technology and more broadly distributed ledger technology to address some of the key inefficiencies of the US healthcare industry? I know you had mentioned that you had already seen kind of a big need in Africa where there was that social stigma around purchasing certain drugs. Do you see a similar or perhaps a different sort of incentive mechanism or gap that distributed ledger technology could have an immediate answer to?
Well, the way I'd answer that is, I'd say I go back to the whole, for example, the credentialing marketplace model. I mean, we've got something called identity.com, which is allowing people to effectively do ID verification and verification of information. So, for example, we could plug into PCX and have those credentials available to people and store it themselves. So for us, it's more about how do you drive value in enterprise and organizations now, because that's how it flows down into consumers. Healthcare is a very difficult beast, as my colleagues on both sides will admit. Like, what gets to the consumers ultimately is a result of a lot of dark closets, you know, and it's not as simple building these end consumer solutions. You've got to go and figure out what's the enterprise value, how do you reduce the costs, for example, from 14% down to 2 or 3%, how do you, you know, HIPAA compliance is expensive, it's cumbersome as well, how do you reduce those things, cybersecurity costs are high as well. And so how do you get to the point where blockchain and DLT technologies are reducing either costs or driving additional revenue? The reality is it's probably not going to drive more revenue than it will do on the cost side. So I think it's more of a cost reduction technology. And so if you can reduce the middleman or the trust points in organizations or between organizations so that you can trust the ledger, then that value will seep down to consumers, hopefully.
To that point of creating trust between untrusted parties, I want to talk a little bit more about why we're even considering or thinking about blockchain technology as a potential solution. Kyle, you had mentioned starting off with public data, since sharing and perhaps putting sensitive information on the blockchain could be more difficult. Corey, do you want to talk a little bit more about the ways that Hash Health is leveraging blockchain networks for more ease, for a greater ease of sharing and hosting private information with other people, given that that seems to be a concern in the minds of traditional healthcare incumbents who are looking at the space and looking at cryptocurrencies in general?
Sure. Well, I mean, privacy is an overarching concern in healthcare, given not only the regulation, but just the right thing to do. This is very sensitive information about people's lives. And that falls in all kinds of different patterns. For example, in Africa, physician information can't be stored outside the Ministry of Health or outside the physical bounds of the country. Brain drain is a real worry, so they don't want their physician credential information stored anywhere else as a means of getting control. When we think about DLT and blockchain, and I'm a firm believer that blockchain is not one thing. It's a host, a polythetic class of distributed technology and cryptography that can come together to solve problems. And what I want to understand first and foremost is what's the problem before we even think about technology. Too many distributed ledgers or fully replicated ledgers are thrown at problems and attempt to stick in many ways, and they're often a misfit. When it comes to privacy, I see two courses of action, and I prefer the easiest one. The other one is the advanced cryptography, the zero-knowledge proofs, which are computationally insanely expensive. Yes, there's innovation. Yes, they're getting cheaper. But get your compliance officer to agree to a zero-knowledge proof while accepting HIPAA regulatory risk, and the conversation is likely not to go your way. The much easier path, and it's radical to say that in this room, is don't share the ledger. Don't share the entire ledger. DLT can be configured in lots of different ways, and point-to-point architectures are more than sufficient to enable trust between counterparties and to actually convert or converse or transact private information that is otherwise highly sensitive. In addition, point-to-point DLT architecture maps the current business relationship around that privacy regulation, at least in the United States. Under HIPAA, you have something called a business associates agreement, which we all sign when we do any kind of work in healthcare, and that's the provider, the covered entity's liability now extends to you and to your handling of that information. And so if I'm going to be transacting business with another party, we're going to have a BAA relationship. And a point-to-point DLT models precisely that BAA relationship. It doesn't broadcast my transaction anywhere else. It doesn't encrypt it, nor does it place necessarily the burden on me as a node operator to run hundreds of different ledgers all at one time. And so I think there is a simple solution to bring distributed technology and cryptography into these business cases without trying to solve how can I share it with everybody and yet hide it from everybody at the same time. Don't try to do that. Just do what works best for the problem at hand. And that's usually point-to-point and not broadcast models.
Kyle, what do you have to say to that, and what are your thoughts about that kind of application of private and sensitive data on a private distributed ledger technology?
I mean, I think there's, as Corey was saying, I agree that trying to go the simple path first and not trying to go the more difficult path. I think there's also a lot of onboarding. You know, as Corey also mentioned, there's a lot of technologies here. There's not just one thing that you need to be aware of. And so onboarding people and getting them familiar, as well as building adoption for some of these things, and moving to, you know, use cases where you can explore, hey, point-to-point may work for this. Let's use that as a starting point because we're more comfortable with that. And then as things grow and we get more familiarity and we prove out some of these other technologies that continue, you know, to innovate, how to employ those and to leverage those. And so I think to me, it's more of what's that meaningful path forward and making progress and saying, hey, well, this is still better than what we got, and this is a better stepping stone for us to grow, versus it being a hard stop or us waiting for some big significant period of time, you know, for everybody to agree and align on, you know, some of these more complicated, you know, scenarios or transaction types.
It's never really a black and white situation. It's oftentimes quite more complex than that, especially when it comes to healthcare. But speaking of some of the regulatory concerns and the regulatory risk out there in putting sensitive data on the blockchain, and especially bringing in a new technology like blockchain into healthcare. Vinny, do you want to speak a little bit to any concerns that you have when it comes to the technologies and the use cases for different healthcare use cases for the blockchain?
Yeah, I think when you look at what Corey was saying, it's absolutely correct. I mean, the use cases for blockchains, as a private blockchains, is far more relevant for healthcare than in other industries. The notion that you should have this broadcast blockchain where everyone's personal health information is on there is kind of it's not foresightful enough if you think that that's going to work. Because when you look at healthcare data, often, and you know, with enough brute force, you could reverse engineer a lot of the hashes because the data sets are very, I mean, the fields are very small. And so you can imagine in 20 years' time or 10 years' time with quantum computing, yeah, I mean, it's difficult to reverse engineer a one-page document that gets hashed. But when you're talking about, you know, 20 bytes or 10 bytes, it actually becomes relatively simple. So now, when people's healthcare information, which typically has these markers are stored on a blockchain, including things like DNA, you could probably determine very quickly what the underlying information is. And if it's on a public chain, that's basically publishing everyone's information, where it may not be readable right now, it will be readable in years to come. And so that's a concern. So I like the idea that you keep it pretty much private for the healthcare, the point-to-point mechanism. And those are sort of things I think about when it comes to healthcare. And this is why we don't see healthcare data as being the right application for DLTs. We see authentication identity as being the right application. So it's more about, do you own certain bits of information? Can you prove that you're the owner of this information? Can you share it? And where does the actual data stored is stored on your devices? So if you can authenticate using the blockchain, but the data store isn't the blockchain, that probably works better.
To that, Corey, would you agree with Vinny in terms of the relative non-use case of blockchain for healthcare? And additionally to that, is regulatory pushback to the vulnerabilities of blockchain technology something that you see is only a matter of time?
That's a big question. I think it's too broad a stroke to say it doesn't apply. I mean, certainly we don't want to put PHI on a fully replicated ledger that's not permissioned. Even if it's permissioned, I still don't like it. I mean, I know my compliance officer certainly would not like it. And so it for us depends on the use case. But you know, beyond storage, you know, kind of solutions, I think about counterparty solutions. So if we need to adjudicate a contract, and that contract requires both parties knowing and being able to verify a piece of PHI, I want to build a system that enables them to counteract and to transact over that piece of information without having to create very complex and overly wrought designs to get them to communicate that piece of PHI for a piece of contract adjudication. And so I think there's a great opportunity for blockchain and DLT in particular, as long as we can architect it correctly to the problem and not for some broader political, quasi-religious vision about blockchain and the unalloyed good of decentralization. I'm not a believer in those things. I've given up theology a while ago. I don't necessarily want to do it for a living now. I will say where there's opportunity is to look for workflows in healthcare that don't have a native technology stack. There's a lot of reuse of technology in healthcare where it's not appropriate. And the prime example of that is the fee-for-service medical claim. It is the end-all, be-all of the infrastructure between a physician and a payer and a pharmaceutical company is around that claim. That claim now is being stretched into use cases it was never designed to do, such as value-based or outcome-based agreements. Right? It is a simple EDI traffic message saying, I did these codes under this contract at this date and time. It's not rich enough from a textual basis to support, but it's being made to support, very badly, outcome-based contracts. And the result of that is that you get very long reconciliation cycles on some of these weird contract types, 18 months. We took financial risk as a hospital. We didn't get paid for 18 months. All the while we had up and downside risk on that contract. That's an untenable business situation, and it's because there's no native tech stack to facilitate those kinds of contractual arrangements. And so when I go into healthcare and I think about use cases, I'm looking for where there's faxes, I'm looking for where people are still pushing spreadsheets to each other in order to accomplish a business function, and that's where I see the opportunity in healthcare.
Speaking to that, in the very last minute that we have left in our panel, I want to talk about the need for collaboration in order to advance different use cases that we see could benefit from could benefit from the technology of distributed ledger and blockchain. In what areas do you guys see as the biggest need for collaboration between blockchain-focused startups like Hashed Health and major incumbent stakeholders, such as Humana in the healthcare industry? Where is the communication lacking, do you think, Kyle?
So I don't know if it's lacking. I think actually across the space there's been a lot of collaboration, even if we're not working on the same use case. But looking at, what's the governance, what's the business model, what are the different opportunities for the technology. Healthcare is very broad, and there is a lot of opportunity for improvement. And so looking at that and saying, hey, Humana is not going to be able to figure out all these use cases by ourselves, right? The incumbents need to partner with other folks and learn from other people, that are exploring this broad space. And then take those learnings and see, how we can share things like governance and business model and protocols and standards and those things in order to be able to scale them together.
Vinny, any unique areas of collaboration that you see?
I mean, it generally is pretty tough working with bigger organizations, just being a startup, right? So you've got a 30, 40, 50 person startup up against a 10,000 person behemoth where, you know, like my experience working with big corporates is there's always someone getting fired, moved, transitioned, reorged. And so the person you're working with keeps changing. And so as a startup, it's really just really hard to build solutions and work with them. So we've taken the approach that we're building the protocols, we're building open infrastructure, Identity.com is open sourced, and we invite you know, the enterprises to look at what we're doing, and if they find an interest, contribute to the code base, contribute to the infrastructure and ecosystem. But you know, when it comes to selling into these organizations, I think, and most decentralized blockchain-based startups, I think, have similar approaches where it's more about collaboration, and I think it's a good thing that the current paradigm we're in means that, you know, GitHub's available and everyone can access the code base and people can just have a look, and when there's interesting use cases, you know, we've been working with Microsoft on their DIF, Decentralized Identity Foundation initiatives, and it's been great because, you know, it's reasonably decentralized.
Kind of build and they'll come to us.
Yeah.
And any last thoughts to add there, Corey?
Just as protocols developed, interoperability between them, either at the language level or at the protocol level, if we can get there, is great. So I'm all in for what's called global composability. I want to be able to write and architect a solution set and have it deploy on a variety of different deployment models. And that's my dream.
Well, thank you so much, Kyle, Vinny, and Corey for joining me today on this stage. And thank you to everyone who was here listening to the panel.
Thank you.